Good evening, everyone. A very warm welcome to ISA National Online PG class. Myself, Dr. Mehek Kindra, currently pursuing fellowship in onco anesthesia at Tata Memorial Hospital, Mumbai. I'll be the screen coordinator for today's class. I welcome my co-screen coordinator, Dr. Tisha. Topic for today's case discussion is anticipated difficult airway management. ISA National conducts online PG class on every Monday at 6:30 p.m. But this time it's on Tuesday. Before proceeding for session, let's invoke blessings of Ma Saraswati. Now I request Dr. Subhinder Bajwa sir, Honorary Secretary, ISA National, to take over the stage and say a few words. Over to you, sir.
Thank you, Meg. Actually, you will be surprised. Your teachers is also today here. So we have welcome our President, sir, Dr. Divetya, sir, to say a few words because after that he will be busy in the conference from the next week onwards. Divetya, sir.
Hi, good evening. Good evening, Dr. Bajwa. Good evening, everyone.
Good evening, sir.
Good evening, sir.
So, this is the event which is conducted religiously every Monday by Dr. Bajwa for the ISA. And some days it's a Tuesday if it's something, but I think without fail, he's always there with that ISA flag. And I think this is just shows the level of commitment that the ISA has for academics, for PGs, and for everyone. This has been Dr. Bajwa has been leading this effort for the PGs every week. I'm also happy, or in a way sad, that this is the last PG class that will be held in. Because after this, when you hold the next PG class, I will no longer be president. I'll be more than happy to be associated with these classes. So I think congratulations to the JIPPER team for organizing this, for taking part in this session. It's a topic which is also very close to my heart on the airway. So I am looking forward to being with you all, and we'll continue to enhance academics throughout for PGs, for practitioners, for everyone. And that's, I think, one of the major aims of the ISA, which we hope to fulfill with this. So thank you all, and please continue with this important activity.
Thank you, sir. You are always been very encouraging, whatever the endeavor we undertake. And definitely this topic for today class must be close to your heart because you are one of the person instrumental in developing the guidelines from our Indian society, from those members of our own fraternity from India, the difficult guidelines, IDA guideline. And definitely this topic has been challenging. It may look very simple. You may have anticipated difficult airway, but how much anticipated difficulties nobody knows until we anesthetize the patient and go for the airway management. So you may have a variable, difficulty levels and how to deal with those. sometimes just the guidelines may not be sufficient to deal with such a situation. Here comes expertise of senior people like Dr. Divetya sir, Dr. Lenin, who has been dealing with these type of cases over a long period of time. So in this type of cases, it's not a theory part; it's more of a practical part. The temperament, the skills, and so many other things are involved in managing such cases. So that is what we are going to have. This is a very, very important class. And without wasting time, we should proceed for the academic feast. So, Mac, you take over from here.
Thank you, sir. Now I request Dr. Tisha to take over the stage and introduce our renowned faculty members. Over to you, Tisha.
Thank you, Mahek. I'm Dr. Tisha, senior resident at Believers Church Medical College Hospital, Tiruvalla, which is situated in Kerala. I'm truly delighted to be here and to introduce our eminent faculty who will be leading today's session. First is Dr. E. Lenin Babu, who is the professor and HOD of Jipmer Institute, Puducherry, with PG teaching experience of 15 years, and his specialty of interest include pain medicine, regional anesthesia. His achievements include he's received a patent and guided residence and also has done many clinical works. He has received the Best Reviewer Award with 15 publications to his credit. I welcome you, sir, to this session. Next, we have Dr. Mohan V.K. sir, who is the additional professor of Jipmer Medical College, Puducherry, with PG teaching experience of 14 years, with specialty interest including chronic pain and transplant anesthesia, and his publications to his credit are 10. Welcome you, sir, to today's session. Before starting the session, few words about the rules of the session. Audience, please keep your microphone mute during the entire session and please keep your video off. You can type your queries in the chat box, or if you have any doubt, you can raise your hand by clicking the reaction option in the bottom of your screen, and all your queries will be addressed at the end of the session. Before we get started, respected faculty, please introduce your residents for today's class. Over to you, Dr. Lenin sir and Mohan sir. Thank you.
Hello, sir. First of all, very good evening to everybody. And I sincerely thank National ISA, Dr. Divetya sir, and Dr. Bajwa sir for giving us this platform to participate in this regular classes. Thank you very much, sir. And we move on to the class, and we have one postgraduates, Dr. Wilson and Dr. Swati. And I have with my little course, Dr. Mohan V.K. is also there. Okay. So shall we go ahead with the presentation?
Sorry to interrupt you, sir. Your audio is not very clear.
I think, Mac, it will be clear by the time the class starts. Sometime minor glitches will be there.
Okay.
Let the PG students should start the class first.
Okay, we'll start. I'll take care of that one.
Good evening, all the respected faculty and members of ISA, as well as the PG students who have joined us today.
Just wait, Rickson. Swati, you turned your mic to mute.
Yes,
so
sir.
that your voice should not echo. Now start, Rickson.
Thank you, sir. Today we are discussing a case of anticipated difficult airway. It's a 70-year-old female homemaker hailing from Kadlur, presented with chief complaints of history of ulcer and pain in the inner side of the left cheek for the past 6 months. History of swelling in the left cheek for past 4 months. History of presenting illness. Patient was apparently normal 6 months before she had noticed an ulcer on the inner side of the cheek for past 6 months, not healing, not associated with any discharge or bleeding. History of pain over the ulcer for past 6 months, which was dull aching, radiating type, increased during chewing, and decreased with medication, completely resolved with medication. History of swelling of the cheek for the 4 months, which was progressively increasing in size. History of difficulty in opening the mouth with gradual restriction associated with feeding difficulty. Initially, it was to solids. Currently, the patient is taking only semi-solid diet. There's history of loss of appetite for past 2 months. History of loss of weight of 5 kilograms approximately, which she has noticed by loose clothes, which were earlier correctly fitting her in the past 2 months. Patient is able to do her regular household activities as in the past. No history of drooling of saliva, no history of voice changes or snoring, no history of difficulty in swallowing of food or breathing difficulty, no history of active fever, cough or cold. Past history, not a known case of diabetes, mellitus or systemic hypertension, tuberculosis, bronchial asthma, coronary artery disease, chronic kidney disease, thyroid disorders, epilepsy, no history of previous hospitalization in the past. Treatment history, patient had been started on chemotherapy, 2 cycles completed 1 month ago. Medication, the patient does not know by name, apart from which the patient is on medication for pain. Personal history, she's a postmenopausal woman, consumed mixed diet, no history of altered sleep patterns, normal bowel and bladder habits. She's a chronic betel nut chewer for the past 40 years, stopped some 6 months back, non-smoker, non-alcoholic. Summary, 70-year-old female, chronic betel nut chewer along with tobacco, came with complaints of swelling and ulcer in the left cheek for the past 6 months. On chemotherapy, probably a case of buccal mucosa swelling of malignant origin for further examination. Shall I proceed to examination, sir?
Yeah, go ahead with the examination. Yes.
On examination, patient is conscious, oriented, poorly built and nourished. She weighs 42 kilograms and height of 155 centimeters. Her BMI is 18 kilogram per meter square. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Vitals as recorded, heart rate is 80 per minute in the left radial artery, regular in rhythm, normal in volume, no radioradial or radiofemoral delays. All the other peripheral pulses are palpable. BP is 110 over 60 mmHg in the left upper limb in the sitting position. Saturation of 99% on room air. Respiratory rate is 18 per minute, thoracoabdominal type. Temperature, she was afebrile. On local examination, on inspection, there is a 5 cross 5 centimeter swelling in the left buccal region, extending from the angle of the mouth to the angle of mandible over the left cheek. Indentation over the skin was present over the swelling. No scars, sinuses, dilated veins. Per-oral examination, on inspection, there is mouth opening restriction, poor oral hygiene and dental hygiene. Halitosis was present. Ulcer was not visualized, no secretion or bleeding from the ulcer, which was noted. On palpation, inspectory findings were confirmed. No warmth, not mobile. Per-oral on a gloved finger. Ulcer was indurated, tender, base was hard. Airway-wise, mouth opening is approximately 1 finger breadth. Interincisus gap is less than 2 centimeters. Modified Mallampati score could not be assessed. Upper lip bite test is class 2. Submandibular space is compliant. Neck movements, full range. Flexion, extension was normal. Hyomental distance and the thyromental distance, sternomental distance are as on the screen, 3.5, 6.8, 13 centimeters. She's partially edentulous and loose lower incisor is present. Nasal cavity, external appearance is normal. No deviated nasal septum. Polyp or subjective patency, she is telling right is better than the left. The cotton wool test also proved that the right nostril was more patent than the left. On systemic examination, CVS, the apex beat was visualized in the left of fifth intercostal space. Just medial to the mid-clavicular line. S1, S2 were heard. No other murmurs were heard on auscultation. On respiratory system examination, bilateral air entry, trachea is in midline. Both the hemithorax moves equally with respiration. On auscultation, but there is bilateral air entry, normal vesicular breath sounds, no added sounds. Breath holding time is around 35 seconds. Cardiovascular examination, apex beat was palpable, half an inch medial to the mid-clavicular line. S1 and S2 was heard, no murmur. For abdominal findings, soft, non-tender, no free fluid, or no organomegaly, which could be appreciated on examination. CNS, the higher mental functions were normal. No focal neurological deficits were noticed. Power in both the upper limb as well as the lower limb was normal. Facial symmetry was maintained.
Okay, can you summarize?
Yes. Summary: 70-year-old female, chronic beetle nut chewer, came with complaints of swelling and ulcer over the left cheek since 6 months on chemotherapy, with examination finding 5x5 centimeter ulcerated swelling in the left buccal mucosa, restricted mouth opening on airway assessment. Patient belongs to ASA2 physical status with anticipated difficult airway for further evaluation and management.
Okay, this patient is planned for surgical procedure tomorrow.
Yes, yes, sir.
So how will you proceed?
I would like to ask for some investigations to know the status of the patient. Complete hemogram, which includes hemoglobin, total leukocyte count, to look for any anemia or any infection, which can be reflected in the complete hemogram. A baseline renal function test, as well as electrolytes to look for any electrolyte abnormalities. I would also like to do an ECG to look for any arrhythmias, because chemotherapy can itself induce some arrhythmias in some patient. Baseline ECG to look for any arrhythmias. Chest X-ray to look for the lung fields for this patient. Apart from this, I would like to take an informed consent to the patient. The plan of anesthesia for this patient will be an awake fiber optic bronchoscopy guided intubation with a flexometallic tube.
The investigations, you do some investigations as a routine assessment.
Yes.
So, for example, in some other hospitals, they may not do the routine LFT or RFT like that. So that depends from institute to institute. Okay. And second thing is any other investigation to decide for your anesthetic plan. What do you want to do? Anything for your assessment?
Apart from the complete hemogram and RFT, I would also look for the liver function test as well as the albumin levels in such patients, because the patient might be cachextic due to the underlying cancerous condition itself. So that also has implications for us in anesthesia management, because highly protein-bound drugs, especially our induction agents like thiopenton, depends on if the albumin level is low, the free fraction of the drug may be high, and we need to titrate the drugs during induction of anesthesia for these kind of patients.
Okay. So another thing, with these patients, generally they do get some CT for the diagnosis of the patient's condition, right?
Yes.
So what is the information you will get as for the anesthesiologist to plan your anesthesia management? What information you will get from the CT scan?
Yeah. From the CT, it might be some a normal NCCT or a CCT of the neck, or involving the brain as well as the neck and thorax. In this buccal mucosa carcinoma, we might look for the extent of the tumor from the origin to whether if there is any infiltration.
No, primarily that will be used for the diagnostic thing from the surgical point of view.
Yes.
What will be the information what you want from the anesthesia point of view? For example, you can look at the nostrils. Here we told about the nasal cavity, which is more which it is more patent. So you can use those images to see which nostril is actually more patent. Is there any deviated nasal septum is there? Normally, when you see the clinical examination, you will be able to see only the deviation of anterior nasal septum, but you will not be able to see the posterior nasal septum, which can be identified in the CT scan. So we are not going to order the CT scan for the sake of doing that, but if the already is available, then you can use that information for additional things. It will help you. Understand?
Yes.
Okay, go ahead.
Um, so after this, we would like to take an informed written consent from the patient. Also, procedure, because we are planning an awake fiber optic in this patient. We need to inform the procedure and explain the procedure in detail to the patient so that they are well aware and psychologically accustomed to the procedure. While because awake fiber optic requires the patient cooperation for doing the procedure successfully. So.
Suppose this patient asks you, why do you want to do awake intubation? I don't want to be seeing what all things you'll be doing. I don't want to get awake. Please give me anesthesia and then do whatever you want. If the patient tells like that, how will you convince? Or will you change your plan?
In this case, the mouth opening is restricted. It is just one finger breadth. Second, the patient is a chronic betel nut chewer. So anticipated submucosal fibrosis is anticipated in this patient. So the mouth opening might not improve even after analgesia as observed in some other cases. So this thing, along with the history of snoring, if it is present, these can indicate difficult mask ventilation also. For us, difficult. So it is a difficult mask ventilation as well as a difficult laryngoscopy and intubation of the trachea.
So the patient is having only snoring is there, or we have any associated daytime somnolence or any other factors are there?
There is no other daytime somnolence. So the patient.
So is there any scoring system available when the patient is having snoring? Is there any other scoring system available to see?
Yes. The screening tool for obstructive sleep apnea is stop bank scoring, which takes into account the history of snoring, tiredness all throughout the day or when they wake up, even after sleep, obstructive pattern of respiration, which they have observed, high blood pressures, then BMI of greater than 35, age greater than 55, and neck circumference of greater than 42 centimeters, and male gender. These are predisposing factors. This is a screening tool for obstructive sleep apnea.
So in your patient, you are having the one is having snoring, and second thing, patient is having restricted mouth opening of around less than 1.5 centimeters, right?
Yes.
These two factors, you are telling that this patient I will be going for awake intubation, right?
Yes.
So let us ask the participating audience what will be their choice of anesthesia. How many of them they will go for awake? How many of them will go for anesthetized? You can just type in the chat box. You can just type awake or anesthetized. So based on the history examination, we have only two findings. I think all of you can do it there in the chat box. Okay, two things are there. One is restricted mouth opening, and second thing is patient is having snoring, awake. Okay, there are a lot of hand systems for awake. Is there anybody who wants to do anesthetized intubation? And somebody has typed as a video laryngoscope. So here we are not talking about the what is the kind of device we are going to use it. When the patient is having a restricted mouth opening, of course, we will not be able to use the video laryngoscope. Right? We are just discussing what is the plan. Is awake or anesthetized. That's first thing, right? Okay, video laryngoscopy is not an option. Okay, is there anybody wants to do anesthetized intubation? We'll just put it there. Sir, I want to do awake anesthetized intubation for this patient. Yes, Dr. Wilson, how do you decide whether this patient we are going for awake or anesthetized?
Yes, sir. One thing is, what are the predictors of difficult airway in the patient? That is what we were talking about. One is restricted mouth opening. So the introduction of the laryngoscopy blade by direct laryngoscopy or even with video laryngoscopy with the one finger breadth mouth opening might not be possible in such a kind of patient. First. Second thing, in this patient especially, has history of snoring as well as the patient is partially edentulous. There is loss of buccal pad of fat because of the cancer cachexia. These indicate a difficult mask ventilation also. So when such kind of indicators of difficult mask ventilation as well as difficult intubation or laryngoscopy and intubation are present, it is a safer option to go for a awake intubation in such kind of patients than go for an anesthetizing. Because once we anesthetize the patient with the induction agents, or with or without muscle relaxant, that is plus or minus, with or without muscle relaxant, the patient's airways as well as the soft tissues tend to collapse. The loss of muscle tone is there if we give muscle relaxant in addition to all these things. This will make a difficult airway into a cannot intubate and cannot oxygenate scenario, which we want to avoid at all costs. This is why we decided to go for awake endotracheal intubation, fiber optic guided endotracheal, nasotracheal intubation in this kind of patients.
Okay, apart from these two, what are the other parameters which will tell you that may not be there in this patient, but what are other predictors? If these parameters are there, you have to consider for awake intubation. What are those parameters? Those are not in this patient. Can you guess? So suppose patient is
yes.
having, yeah, please go ahead.
Apart from this, there are other awake intubation. Already the saturation level of the patient is lower due to some other lung condition. We don't want to lose the oxygenation of the patient in such kind of scenario. So
okay, basically the patient who is having a reduced apneic time.
Yes, yes.
Maybe patient may be having a increased oxygen consumption, or patient is having a baseline low oxygen saturation. Whenever
Yes.
the groups are having a less apneic time, when having a morbid obese patient, there also. Okay, then same thing when the patient is having a increased risk of aspiration, or when the patient is having a difficult. See, ultimately, when you are going for anesthetized intubation, you will be going for, in case you going for a rescue airway disease, you go for invasive airway. So if you find it that is difficult, the backup plan is difficult, that case you straight away go for the awake intubation. So those are all the criteria. So now this patient, all of you are preferring to have awake intubation. Now suppose this patient is uncooperative. Okay, 70-year-old lady coming from a village, she's telling we are going to give the nebulization, whatever technique is there. Suppose patient is uncooperative, then what do you do? Do you consider this intubation in this patient?
For such kind of patients who are uncooperative, there is a provision to give low doses of sedative agents like dexmedetomidine, which produces awake sedation in patients. and makes them more comfortable or cooperative. Still, the patient cooperation is of utmost importance in awake fiber optic intubation patients.
Okay. So there are some conditions where you have to go for a sedation and then do awake intubation, or sometimes you need to go for the anesthetic intubation as well. Okay, that depends upon the individual patient characteristics and the experts' experience, what the help available. All those factors we need to put it into account and then decide ultimately. Okay. So for this case discussion, we plan, okay, we are going for an awake intubation, right?
Yes.
Okay. We go ahead with the plan.
Informed written consent was taken for this patient. Then there are some pre-operative preparations which we routinely advise before the day of surgery, like NPO guidelines, solids 6 hours, clear liquids up to 2 hours just before the surgery. Then antibiotic sensitivity test and xylocade sensitivity test. Pre-medications, on the night of surgery, we would advise a tablet, a H2 receptor blocker tablet famotidine 20 mg per oral. On the morning of surgery, we would like to advise pre-medication, tablet famotidine 20 mg per oral, and tablet metoclopramide 10 mg per oral, which is a prokinetic for hastening the gastric emptying. Xylometazoline drops, 0.1%, 2 in each nostrils to be applied just on call before the trolley arrives from the operation theater. Injection glycopyrrolate, which is used as an anti-xylagogue, 0.4 mg IM on call for these patients. Anesthesia plan for this patient will be an awake fiber optic bronchoscopy guided intubation with 7-size flexometallic endotracheal tube, which is introduced through the nose, followed by GA with positive pressure ventilation and 2 wide-bore cannulas with invasive BP monitor. On the day of surgery, we would like to prepare the... Yes.
Yeah, Dr. Christian. So here, once you make a plan of awake intubation, do you expect any difficulty at some point of during your airway management? And what is your plan for those anticipated difficulties during your execution of your plan?
Okay. While planning for awake fiber optic, one is the patient should be cooperative enough to withstand the awake fiber optic bronchoscopy guided intubation. One. So we might need to use sedative agent like a dexmedetomidine for this patient to be more cooperative. That is one point.
Yeah, one thing, yeah, correct. So one thing, the patient have some anxiousness, or patient can have a difficulty in cooperating with the technique. So that could be one difficulty. So we need to have a plan for that. Okay. Other concerns?
Second one is we have planned a 7-size flexometallic endotracheal tube for this patient. A smaller size as well as a larger size tube should be in backup. Mainly a smaller size flexometallic tube, or different kinds of normal size, normal cuffed endotracheal tubes also should be kept available because we might face difficulty while introducing a larger size endotracheal tube in this case.
So what do you mean by normal? What do you mean by normal tube?
PVC, cuffed PVC ET tube is what we mean.
Okay, all right.
Third thing is there might be difficulty while introducing through the nose. We are introducing the flexometallic tube. During that time, we can encounter difficulty passing the endotracheal tube. It can bleed during epistaxis can happen. So to reduce that incidence, that is why we have prescribed xylometazoline drops pre-operatively to cause some vasoconstriction in the area. Third is secretions are one of the important hindrance to awake fiber optic bronchoscopic guided intubation. So that is why we have given anti-sialagogues to reduce the secretion and dry up the secretion. We can give it either through the IV route or as well as the IM route. We have chosen the IM route because on call, once the trolley arrives, they give the intramuscular injection, which takes around 20 to 30 minutes for its action to achieve, and it lasts for about 4 to 6 hours during the procedure. Same way, through the IM route, we can give it as 10 mics per kg IV dose, which duration of onset of action is around 1 to 2 minutes, and the duration of action is around 2 to 3 hours for such a.
Okay.
So, yes.
Some of the
I have
difficulties.
a question.
Yes.
Yes.
See, you said you will choose awake. Said anesthetize the problems of difficult mass ventilation, right? And aspiration risk.
Yes.
Can you think of the maneuvers which are required in anesthetized patient, which are not required when the patient is awake, which makes it cause difficulty with anesthetist in this situation?
Yes. In an anesthetized patient, one is the patient is not able to maintain the airway. Second, tongue fall is one of the important problems. So in an awake patient, since the patient is arousable, this level of sedation will be just arousable when you are about to call, even if the patient is sedated. You can ask them to protrude the tongue. So the tongue fall is not a problem during awake intubation. One. Second thing is.
So what?
Yes.
What do you do to open the airway if the patient is anesthetized?
Generally, we give a head tilt, chin lift maneuver, and a jaw thrust maneuver in this case for opening up the airway.
Anything else? We can hold the tongue, right? You can hold the tongue
with a gauze piece. Yes.
Yes. And here, that is also a problem, right? We don't even have enough space to do that.
Yes.
Yeah. How will you prepare the theater for this case?
Yes. On the day of surgery, preparation of the OT include a proper OT temperature should be maintained. Anesthesia workstation. Yes.
Yeah, you need to be very specific. It's not usually generalized terms. I need to have a proper OT. You have to tell that if you want to have mention the temperature, you need to mention I want this temperature like that. Okay.
Yeah.
All right.
Yes.
Yeah.
Temperature of around 25 to 27 degrees Celsius normally maintained in the OP. Second is anesthesia workstations to be checked, circuit to be checked, and leak specificity for these kind of thing. Second is suction apparatus to be made ready. Resuscitation equipments like defibrillators, ambo bags, all to be kept ready. Drugs for emergency drugs as well as the anesthesia drugs to be prepared. O2 oxygen sources apart from the workstation O2 supply, auxiliary cylinders with O2 supply or from the directly from the gas pipeline to be made ready. For this preparation of difficult airway trolley, which include direct laryngoscopy with 3-size and 4-size Macintosh blade, McCoy blade, as well as a short
Why
handle.
do you want to keep a laryngoscopy for this patient?
Sir?
No, but why do you want to use a laryngoscope for this patient?
Even though yes, sir. Difficult airway trolley has all these components. Even though we might not be using that is the primary plan during even the direct laryngoscopy should be kept in the difficult airway. The blades can be used for depression of the trunk or for using for finding which nares are better or open during the thing. Also, we can use laryngoscopic blades for those cases.
Yeah, it may not be useful during the at the time of intubation. Maybe it might help the time of extubation. Maybe after the surgery, in some procedures, it might mouth might get opened up in those cases. Definitely, it's not going to be useful at the time of intubation. But okay, fine. As a completion sake, you can tell. Okay, go ahead.
Then endotracheal tubes of appropriate size. Since we have planned a 7-size flexometallic endotracheal tube, lower sizes of 6 as well as 6.5 flexometallic tubes to be kept ready. PVC ET tubes, cuffed ET tubes of 6.5, 7 also to be kept ready. Then laryngeal mask airway, especially the second generation ProSeal LMAs of 3 size to be kept ready for this.
Now, will you be able to place a supraglottic airway device in this patient?
With the restricted air mouth opening, it is unlikely to be helpful in this kind of patients initially.
So, what is the minimum mouth opening is required to place a supraglottic airway device?
At least not two finger breaths should be.
What do you mean with finger breath? Because my finger is bigger, your finger is smaller. That is not a standard way of measurement, right?
Yes,
so you need to be more specific.
It is of the patient's finger we measure this finger breadths.
Yes, if suppose I come as a patient, my finger is having a medium length. Suppose the patient is the heavy patient comes, the morbid obese, maybe they have a thick fingers. Okay, so we should not be telling in a finger breadth. We need to be telling in centimeters. For example, if your mouth opening is 2 centimeters, you can place a classic element. Okay, what about the ProSeal element? How much the mouth opening required? The minimum mouth opening required?
At least 2.5 centimeters, 2.5 to 3 centimeters at least.
Yeah, at least 2.2, more than 2.2 is the minimum required. The same way, so if you want to use the laryngoscope blade, what is the minimum mouth opening required? So we have the length of the blade, how much it will be there. So we need to take
length or width.
Yeah. The inter-incisional gap, how much it will be enough to.
So it should be at least greater than 3 centimeters.
Yeah. So minimum
so
3 centimeters.
For us to insert a laryngoscope blade.
Yeah. Yes. So, but there are some blades is available where there's a shorter that is there. So in that case, it need to be individualized. So what is the patient's mouth opening and what is the scope I am having? Only thing is you will not be able to have the space to leverage sometimes if you want to do it. So it has to be individualized. But as overall, you need around 3 centimeters for the laryngoscope blade to be placed. Okay. Okay, go ahead. Yeah.
This measurement with finger breadth, how is that useful? We have always been using finger breadths, right?
Sir, finger breadth usually in extremes of age, like when we compare it with a child, and relatively the size of the blade which we are going to use for it is a relative terms of like the patients like small children as well as like or in the extremes of their
okay, see this measuring in centimeters is useful in situations like specifically talked about insertion of LMA, insertion of laryngoscope blade. Depends on the size of the laryngoscope blade. irrespective of the patient size. Okay, so if you want to place a processing element, we need this much width. So it depends on the width of the element, which is fixed. So you can talk in terms of centimeters. During this airway assessment, you have mentioned the hyomental, thyromental, sternomental distances in centimeters, right? Those distances might be better in finger breaths, because here the airway size is related to the patient size. So a 3-finger breath for a baby and a 3-finger breath for an adult in relation to the airway size is going to be appropriate. Ease of airway uh, management. But when you use this mouth opening for laryngoscope blade or for elimination, centimeter is better, right?
Yes.
So we are talking about the arrangements in the difficult airway car. What are the things
Yes.
we'll be keeping? Go ahead, please.
Airway adjuncts like nasopharyngeal airway, oropharyngeal airway, according to the patient size and characteristic, to be kept ready for this. Bougie, stillet, and Magel's forceps, because we are doing it with a flexometallic tube. So Magel's forceps also to be kept ready. Cricothyroidotomy set with non-kinkable cannulas to be kept ready. Fiber optic bronchoscope with monitor or amboscopes, as our institute uses an amboscope for all these procedures. These are the things. Apart from this, nasal prongs to supplement oxygen while the patient is undergoing the procedure, also to be kept ready with the O2 source.
Okay, you have mentioned about the video bronchoscope, that is the ambuscope, or
Yes.
laryngeal flexible fiber optic scope. So what is the difference between these two, your ambuscope and your flexible fiber optic?
This fiber optic bronchoscope, flexible fiber optic bronchoscope, works on the principle of total internal reflection. It is like one image which is found at the end through lenses will be transmitted all along through the fiber optic and projected through the eyepiece, as well as can be projected on the monitor. On amboscope, on the other hand, which our institute is using, is a video guided. There's a camera at the tip of the flexible scope, and that is projecting through the cables directly to the monitor. We do not have an eyepiece to look through the thing, but only it can be projected in the monitor. We'll have to visualize the monitor while going for this procedure.
Okay. What is the important difference between these two devices when you are working with a device? One thing, as you mentioned, one need a video camera to visualize, or the fiber optic we can directly see from the eyepiece.
Yes.
Right? So what is the difference in the working pattern, or it is more easier to do it handling? Which is easier to handle while you are doing this scope?
Handling, like it is better with the video guided flexible scope, because this for fiber optic in. So,
okay, what I'm asking is, if you are going to use a flexible bronchoscope, flexible fiber optic bronchoscope, you need to keep the scope always tight. In case of any small bend is there, it might damage the fiber optic bundles. So you need to be very careful when you are doing the manipulations throughout the procedure. But if you are using a video bronchoscope, that concern is not there. There is no fiber optic bundles there in the video bronchoscope or the ambuscope. You can comfortably do it. You can just take that that damage to the scope from your mind. You can concentrate the patient. Okay, that is the main issue. All right. Fine. Anyway, that depends. Whichever is available, they can use that scope. Anyway, so now we arrange the scope. Fine. So OT is arranged for you now.
Yes.
Okay. Shall we go ahead?
Yes. Now, we need to prepare the patient after confirming once the patient arrives in the pre-op holding area. The consent, whether the consent is taken or the informed written consent is available. Second, NPO, whether the patient was NPO to be first verified. Second, all the pre-medication which we had already given hasn't been given appropriately at the appropriate dose, as mentioned from the nursing officer's record from the ward. These are the things we will verify. Now, we need to prepare the patient. Once more, we need, in the pre-op holding area, we need to explain to the patient the exact procedure which we are going to do and the need for cooperation. And so, here in the pre-op holding area, after now we can take the patient inside. We have planned to do a awake intubation. So once the patient is inside, we need to verify whether they have a IV line already placed and present, or if it is not present, then we'll have to secure an IV line. ASA standard monitors to be attached, like pulse oximetry, NIBP, ECG, to be work and functioning. Then once all the monitors are attached, all the baseline vitals are verified. Once more, we'll start with the preparation of the topicalization of the airway, making the patient ready for awake fiber optic intubation. So for this patient, we had planned cotton to, we need to topicalize the nose as well as nasopharynx. Then below in the oral cavity, and the posterior part of the pharynx. Then the trachea as well, epiglottis and the associated structures and trachea. For this, we have with the cotton tip swab soaked in 2 to 4% of a lignocaine solution with ADR, 1 in 2 lakh dilution ADR along with it, placed in the dorsal surface of the nose to block the anterior ethmoidal nerve, which is a nerve from the ciliary ganglion, which supplies the anterior part of the nose to be placed. And the second cotton tipped swab, which is dipped in the solution to be placed at around 45 degrees to the hard palate, so that it goes to the posterior part of the middle turbinate, where there are 2 nerves mainly, the greater palatine and the lesser greater palatine and the lesser palatine nerves, which are anesthetized for the posterior part of the nostrils, because our intubation is guided through the nose, or the nasotracheal intubation is planned for this patient. These needs to be left for 5 minutes so that the nerves are anesthetized, because they are just underlying or just beneath the mucous membrane. So 5 minutes would be a sufficient time to anesthetize. Second, we'll be spraying 10% lignocaine spray, asking the patient to put out the tongue in the sitting position. Lignocaine spray to be sprayed in the posterior pharyngeal wall, 2 sprays, which is 10% of lignocaine. Each puff will give around 10 mg of lignocaine in this. Third one is we have planned to go with the spray as you go technique. So for this,
1 second.
Sir.
So this patient you mentioned about the spray using the 10% lignocaine.
Yes.
Considering this patient is having a submucosal fibrosis, will you be able to ask the patient to put out the tongue, and then will you be able to spray the posterior pharyngeal wall and do it?
So with restricted mouth opening, yes, there will be difficulty of spraying, but the patient is able to have food with such a even with such restricted mouth opening, even though if it is semi-solids. So that spray which is used has a long stick for instilling the drug, which can be introduced through the one finger mouth opening. As far as the patient can do it, we can do it. Or alternative to this is lignocaine gargle. 2% lignocaine gargle also can be given so that the patient can gargle it in the posterior part of the tongue so that it gets anesthetized. This is one of the
Because
backup
if you are
plans
going
in
to use
case.
the 10% spray,
Yes, sir.
when the patient is in this patient, it will be difficult to anesthetize the posterior one side of the tongue. So as you are planning to Sego technique, maybe you can prefer to use the Sego technique and then do it. Or else you can
Okay.
try some oral gargling. So the
Okay.
10% spray may not be working for this patient because the patient will not be able to roll the tongue out. Okay.
Okay.
And it all about the anesthetizing the nasal cavity.
Yes.
Will you be doing only on one side or will you be doing on both sides?
It will be done on bilateral nostrils, sir. Both the sides it has to be done.
All right. Okay, fine. Okay, then go ahead.
So once we are done with these two procedures, now we are going to introduce the fiber optic bronchoscope through the nase. We need to verify that with the cotton whisk test or with the laryngoscope blade, which nose is more patent, because cyclically every 40 to 45 minutes we alter the nostrils. So while breathing, so which one is breathing more patent? We need to verify beforehand. Also, one more thing is supplemental oxygen through the nostril, which we are not using with the nasal cannula at 2 to 4 liters of O2 insufflation. Insufflation during the procedure also is recommended, and we follow those things.
Have you calculated
yes.
the local anesthetic toxic dose in this patient?
Yes, sir. Sir, according to British Thoracic Society, as well as the Difficult Airway Society, also recommends a dose of 8 to 9 milligram per kg of local anesthetic for topicalization of the airway. For this patient, the weight of the patient is around 41 kgs. So the toxic dose will be 328 milligram for this patient. Because of this a small dose of anesthetic, this is based on the lean body weight, and this patient's body weight we have taken 41 kgs. Based on this, 328 is the toxic dose for this patient, sir. So we want to keep it well below this. So we have already calculated based on this patient characteristic. Initially, the 2 cotton swabs will be around 1 ml, 1 ml each on both the cotton tips. There is some 4% lignocaine with ADR. So it is around 40 milligrams of the each nostril, 80 milligram of for each nostril. Same way, 2% lignocaine gargle, if we are giving 20 milligram into around 5 ml, we'll have to give 3 to 5 ml at least. So 5 ml will be around 100 milligrams. So as spray as you go technique, we are using 4% lignocaine of 1 ml with 4 ml of air in the syringe. So for 40 mg for 3 times, we'll be able to spray without exceeding the toxic dose for the patients. Did I answer your questions?
Yes, continue with your.
Yes. So with the spray as you go technique, we'll introduce the flexible fiber optic bronchoscope through one of the nares and slowly navigate downwards until we reach the. Yes.
Again, you have to be more specific because you've done the assessment, and then you need to choose through which nostril you are going to place the fiber optic, right?
Yes.
So you need to tell them either right or left or whatever.
Yes. Through the our subjective patency test proved that was in favor of the right nostril more than the left nostril, and so we are going with right. We'll introduce the flexible fiber optic scope through the right nostril in this patient. Right nostril. We'll go up to the where we can visualize the.
There are two techniques that are available now. Either you can put the tube first into the nasal cavity, followed by the fiber optic into the tube, or you can put the fiber optic first and then later you can railroad the tube. So, which technique do you prefer, and what is the reason?
Okay. Sir, we have anesthetized the nose as well as the base of the tongue with the gargle, what we have given, sir. We want to do a scopy first and anesthetize the near the cords. We'll have to wait during that procedure for 30 to 60 seconds. So we have planned to introduce the flexible scope, spray the lignocaine, spray of 4%, then come out. Then we will railroad the tube in the second go when we are going the things. That is what we have planned for this patient.
Actually, what happens now is the tube first technique. What normally will place the tube into the nostril, even though the selection of tube is arbitrary one. You look at the fingertip, you look at the CT scan findings, and you select the tube arbitrarily. And when we are going to put the tube, and there is a even though you have prepared the airway, you given the vasoconstrictor, still if it starts bleeding from there, all the bleeding blood is going to trickle down to the tube to the throat. So it might come into the vision in case of a difficult thing where you are taking more time. So that blood can come and then obscure the vision of the fiber optic. So that is the reason they prefer not to put the tube first. That is one thing. Suppose if we are doing a fiber optic first, and then when the fiber optic goes inside the trachea and then confirm the carina, and then when you want to railroad the tube, that time the tube may not go because the tube selection may be wrong. That time you may have a difficulty in railroading the tube. So that's the reason. So they need to have understanding what to be done first, the tube first or a scope first. Clear?
Yes.
Okay. Now you want to put the fiber optic first, correct?
Yes.
Okay. Go ahead.
Yeah. So once we have reached, we have navigated through the posterior part of the tongue. There might be a.
But how do you? What will be your goal? How do you navigate this scope?
Yes, sir. The scope, one, it should be held straight if it is a flexible fiber optic bronchoscope. Second is it shouldn't touch any of the walls of the airway. So that creates difficulty in visualization. In case we are touching any of the walls of the pharynx or larynx or the base of the tongue, we need to withdraw it slightly and introduce it in the path where the air column is present. That is how we are supposed to introduce it. If there is any,
how do you identify the airway? How it looks like?
Initially, through the nose, when we are introducing itself, there will be a black column which allows easy passage. That air column is looking black on the fiber optic bronchoscope. That might guide us through the entire procedure. Second is when we touch the walls, it might get pinked out or red out, which we can see on the amboscope or the flexible fiber optic bronchoscope. So we need to withdraw it as well as do a gentle suction of the secretions if they are present. to proceed into the airway particulums.
Yeah, you mentioned correctly. So while you are advancing the scope, you need to keep the black shadow in the center of the image. Okay, that is why, because if you are going to touch the mucosa, one thing is, if you try to keep on pushing, it might traumatize the mucosa and then start bleeding from there. All right. So that's the reason you need to keep the black shadow in the center and then keep on advancing the scope. Okay.
Yes.
Done.
Once we have seen the epiglottis and the cords, we will be spraying 4% lignocaine as one push, 1 ml of 4% lignocaine with 4 ml of air, which will disperse the lignocaine over the surface. We need to wait for 30 to 60 seconds for the action of the lignocaine to come into effect. If we are still without withdrawing the tube, we can see that the movement of the vocal cords has slightly reduced after the lignocaine spray also.
Yeah, Dr. Hickson, while you are going to inject your local anesthetic, what is
Yes,
the important precaution you will take it?
yes. Important precaution will be the suction, if it is connected, should be clamped or disconnected from the thing, or if O2 insufflation is going on, it can continue at 2 to 4 liters per minute for EC dispersion of the.
Yeah, if you are doing the bronchoscopy, the suction should be always connected. That's how you prepare the bronchoscope, correct?
Yes.
So at the time of injection, the suction should be stopped. Either you block it or take it out or whatever. Because if you are going to keep the suction, the local anesthetic might get sucked it, right?
Yes. Yes, sir.
All right. Okay. Suppose while you are doing, you are there in the, you not reached the glottis, you are just there in the posterior pharyngeal wall, and during the patient's breathing, it is getting fogged. So how will you avoid this? Is a frequent problem. How will you avoid the fogging while doing the fiber optic bronchoscope?
Fogging with fiber optic bronchoscope. One is we can withdraw it slightly, remove the fiber optic scope, and just before introduction, we can soak it in saline or Savlon initially, and then saline to clear the camera port which is present. Second, when the patient is breathing, it will be there. We can put a suction, gentle suction while we are going near that, so that it doesn't fog that point.
No, actually, it is the other way, because when you are going to do the suction, it's not going to help. So basically, what happens is when there is a expired air comes from the trachea, that is going to come and fog near your fiber optic lens, correct? So what you should be
Yes.
doing is you should be giving either one technique is you give oxygen through the suction port. Instead of connecting the suction, you can give oxygen. So that oxygen, it will have served two purposes. One thing, it is improving the oxygenation, and second thing, it is going to kind of displace what is the expired air comes, so that the fogging will be avoided. Okay, that is one technique. And second thing, like as you said, we are going to use nasal forms. So instead of giving a nasal forms with the 2 liters, you can give more oxygen flows. That way, that is also going to displace little bit the expired gas. So that way, you can avoid the fogging during that thing, right?
Yes.
Okay. So that's why the suction port will be useful at some point.
Yes.
Yeah. Okay.
So once we have sprayed and we have anesthetized the thing, we'll once we have sprayed, then we'll take the fiber optic bronchoscope outside. We'll rate load.
How do you navigate from the oropharynx to the trachea? What are the maneuvers we'll be doing to facilitate that?
Okay. With the fiber optic bronchoscope, we can do three techniques to maneuver. One is introduction as well as withdrawing of the scope from the manually by inserting as well as withdrawing the scopes. Second one is we can means anti-version and anti-version and flexion with the control knob which is present in the fiber optic bronchoscope. The range of motion for this will be anteriorly, it can go from around 120 degree to 180 degree, and in the posterior part or the retroflexion can go up from around 70 degree to around 130 degree. So the total range of motion for this will be around 70 to around 130 degree. That is the range of motion for this bronchoscopes. Third motion will be rotation motions or slight rotation to keep the bronchoscope in the midline without touching the walls of the mucosa. That is what we'll be doing to maintain it.
So that is the maneuver. Yeah, that is those are the maneuvers which we can do with the fiber optic. But
Yes.
how will you do it? Suppose you are there in the posterior pharyngeal wall. After you introduce to the nostril, you are looking at the posterior pharyngeal wall.
Yes.
Now, what maneuver will you do to go inside?
Okay. Now we can ask since the patient is awake, you can ask the patient to protrude the tongue outside. So
cannot do it.
To the extent whatever is possible, or
so that's why it is important to keep the patient position is very important. So in this patient, instead of keeping in a supine position, you can have a slightly extended position that will try to open up the airway. Okay, so that thing we need to do before only.
yes.
Okay. Okay. So what I was expecting is while we are going to the posterior pharyngeal wall, and then you slightly do the anti-flexion. Okay. How do you remember what is the movement? If you are going to press the lever down, control lever, what will be the movement there at the tip?
It will be anti-flexion.
Okay. The easier way to remember is a seesaw movement is there. When you are going to press the lever,
downwards, it moves in the upwards.
Yeah. So it's a seesaw, right? You play a seesaw game, no? So once you press down, the tip of the bronchosa, that is anti-flexion, it goes up. You'll be looking at the epiglottis.
Yes.
So once you look at the epiglottis, then next, how will you maneuver to go behind the epiglottis? How will you bypass the epiglottis?
Bring it to the slightly bring it to the advance the scope, slightly bring it to the neutral position, and or we need to go behind the epiglottis. So then we can retroflex the scope slightly and to introduce it between the cords. While introducing between the cords, you can ask the patient to take deep breaths. That time you can advance the scope, or you can ask the patient to phonate also.
Yeah. So the first maneuver is from the posterior pharyngeal wall, you do a anti-flexion to look at the epiglottis. And then you slowly advance the scope. Once you come near the epiglottis, again you retroflex it so that you go below the epiglottis to bypass the epiglottis. Once you advance a little bit further, again you try to anti-flex it so that you'll be looking at the cords. Okay, then after that, once you look at the cords, the next what maneuver will do?
Sorry to interrupt everyone. Dr. Rickson, can you stop screen sharing?
Yeah, go ahead, please.
Yes. So once we have looked into the cords, once we are looked into the cords, after the we have visualized the cords, then we will come to the neutral position, almost to the neutral position. Slightly advance the means we are anti-flexing during the initial thing. We'll slightly come to the neutral position. The cords will be just in front of you. Between the thing and slightly advance. That time we can ask, because the cords will be still moving because the patient is awake and respiration is going on. So we can ask the patient to take deep breath. That time during expiration, these cords will open up, and then we can introduce the.
Yeah. So the maneuvering is like as you said earlier, you correctly told. Before the epiglottis, again you look down. Okay, to retroflex, bypass the epiglottis, go beyond it, and then try to antiplex it. You look at the cords. Once you go into the cords, again you need to retroflex again to come the look at the tracheal rings, right? Okay,
Yes.
then so once you see the tracheal rings, what is the next step?
Again, we need to spray 4% lignocaine to anesthetize the subglottic structures. We need to visualize till the carina to be while we are doing a fiber optic bronchoscopy. And so to anesthetize the subglottic structures, we can once more spray, wait for 30 to 60 seconds, and then we can proceed to visualize the carina and the by direct by advancing the scope till the carina.
Okay, so you should not be very fast in advancing the scope. You spray and then wait for some time, at least some 30 seconds for the local to be acting, and then move ahead. Okay.
Yes.
So when you railroad the tube, once your fiber optic is there inside the trachea, when you railroad the tube?
So during the second time when we are introducing after the second first set of spray, we'll withdraw the scope totally. We'll railroad the tube, then we will advance to see the between the cords, and we can railroad the tube during.
No, I didn't get it. What did you say?
So first time when we spray for the base of the tongue or the epiglottis, when we are seeing, we'll spray and we'll take out the scopes. We need to visualize it first at epiglottis level. We need to spray, then go deeper through the cords, spray, and then come out. Then again do the scopy from first, and that time only we'll railroad the tube and we'll.
No, you mean to say you do the only the fiber optic without the railroading the tube. You do the fiber optic once first time. You anesthetize the
Yes.
airway.
Yes,
Then
sir.
take it out, and then no, that is not the way to do it. No, fiber optic. So you railroad the tube in the first attempt itself, and when you are going to anesthetize the airway, that time only you need to keep the tube railroaded ready. Okay, and then you anesthetize. Once anesthetize, then you can do it. Only thing is when you are doing the anesthetizing,
Introduction of the tube will be delayed.
Yeah. So always once you anesthetize, wait for some time and advance it. Once you visualize the carina, then you can railroad. It's not like two-step procedure. Once you do the fiber optic and then another.
You are not audible.
Sorry, sir, I'm not able to hear this.
You have muted yourself, sir.
Oh, sorry. Okay. So normally that is not the way to do it. So first, when you are railroad the tube and keep it there. That's why you prepare your fiber optic. You keep your tube railroaded. You attach your section. You keep your lens, your vision clear. Check the orientation of the camera if you are going to use the video camera there, and lubricate the fiber optic cord, and then do it. That's the way you do it. So it's not two-step procedure, it's only single step, right? Okay. Then, so now you put the trying to railroad the tube, right? And you are not able to railroad the tube. What will you do? The tube has gone into the nostrils, and you are trying to advance this tube. After some time, you are not able to advance the tube. What will you do? Do you understand my question?
Yes, sir.
Okay.
I just have a doubt, sir. Whether have we crossed the nostrils, or where is it?
No, in that process, while the fiber optic is inside, you are able to see the carina and you are trying to railroad the tube. You are facing difficulty. You are having some resistance. It could be at multiple levels.
Yes, sir. Initially, the resistance might be at the level of the nose or the nostrils at the meatus level itself, sir. So that time, a gentle rotational motion, we will not push against any resistance um, uh, because there can be mucosal injury because of the if we push against resistance. So with a gentle rotational motion, we'll try to slightly introduce the tube. If it is the nasal, it will be a well lubricated tube. So with a slight rotation motion, it might be able to.
Okay, here are two things we need to keep in mind. One thing is what is the anatomy of the nasal cavity? We have the meatus are there, we have terminates are there. Where exactly you are going to insert your tube?
Along the floor of the nose, that is how we introduce the.
Okay.
Which is
It
the
should be at
meatus?
the, yes.
Sir?
That's inferior meatus, right?
Inferior meatus.
Under
Yes.
the you go under the inferior ternate.
Yes.
What are the
Okay.
problems you are avoiding by going there?
One, it is the um, it is curved and a natural passage for the tubes. Second is like there are vessels which are in the middle as well as the superior meatus areas. So that we will avoid during injury to those we will avoid. We will avoid epistaxis in the surgery. Yes.
And all the sinus openings, sinus is opening or in the middle meatus and the superior meatus. What is there in the inferior meatus? Is there any opening in the inferior meatus?
Inferior meatus.
Only the nasolacrimal duct opens there. No, nothing there.
Okay. Now, while you are trying to push the tube, you are having resistance at multiple levels. Suppose you are feeling the resistance here at the nostril level only. So what are the techniques available to improve it?
One is like um, through gentle rotational motion, we can try to advance the tube, sir. If there is not much resistance, we can proceed with gently rotating the tube and introducing the tube. In case there is more resistance, then we'll have to remove the tube and use a smaller size tube because that size tube, or we can go for the other nostril. If suppose there is some mucosal injury and bleeding, we need to go for the other nostril. That is what we.
So you have selected the flexometallic tube for this case, no?
Yes.
Suppose we are using the PVC tube. Is there any other technique available to overcome this problem?
If it is a PVC tube, it is in the natural curvature. So this we can use for a blind nasal intubation also can be with fiber optic. I'm not aware of.
No, not that. In case of
Yes,
PVC tube, you can soften the tube while putting it in the warm saline, so that
yes.
you can negotiate it through the nostril. That is the idea. Okay, so that is to negotiate at the nostril level. You can change the size of the tube. If it is a PVC tube, you can warm the tube beforehand. Or before you railroad it, you can warm the tube and then keep it there. Okay, if not helping, you have to go for the other nostril. Nothing working, you have to go to the smaller size tube. All right. Okay. Now, once the tube is gone beyond the nostril, then where can I find the resistance?
One is the posterior pharyngeal wall. It can hinge on some structure in the base of the tongue or the posterior pharyngeal wall, because it is a very flexible tube which we are using, flexometallic tubes. That with limited mouth opening or whatever protrusion of the tongue, if the patient is able to do, or a slight extension at that point, neck extension might help us navigate the.
Okay, usually the problem will not happen at pharyngeal level. It will go easily because we are going to railroad the tube. It won't happen at that level. Where exactly that tube can face the resistance?
Arytenoids, usually the epiglottic bone, the arytenoids, those it might hinge there and not able to pass the tube through into the through the vocal cords. That is what.
Okay, so what is the problem? How can you overcome that one?
Um, we can do. We can extend.
First of all, you need to understand why the problem happens at the level of the epiglottis or at the arytenoids. What do you call that? Yes, Dr. Swati.
Yes, sir. It's called as the hung up effect, sir. So we have to actually turn the tube 180 degrees anti-clockwise. So if at all we are going to turn it anti-clockwise 180 degrees, we will be able to uh, bypass this one, sir. Or otherwise, if at all with that maneuver also we are not able to do that, then we have to turn it back to the same position and rotate it 180 degrees in the clockwise direction, sir.
Okay, the first thing, why it happens?
Sir, that is because the tube, the bevel of the tube is being hinged over the arytenoid, sir.
Yeah, so that is happens because the if you put a proper size tube, the tube is just next to the fiber optic. There is no space between the fiber optic and the endothelial tube. If you railroad it, it will go smoothly. The problem happens only when there is a small size fiber optic and you put a bigger size tube. There is a gap between the fiber optic and the tube. That's the reason when you go near, it will the leading edge of the tube will be going and hitting the arytenoid. You will not be able to do it. So, what is the maneuver you do? You should do it.
So we will be rotating anti-clockwise for 180 degrees.
Okay, by rotating to 180 degree, how is it going to help? So now with the tube is hitting it, if you are going to place a tube in a normal way, where the leading edge will be, the leading edge will be hitting the right chord, right?
Yes, sir.
If you are going to turn the tube to 180 degrees, what will happen?
Actually, it will rotate towards the left side.
No, it's not 180 degrees. Can you guess now?
Okay, sir.
It is actually 90
90.
degrees, anti-clockwise 90 degrees,
Yes.
so that the bevels is goes directly into the between the cords.
Okay, so that is 90 degrees. Is it clockwise or anti-clockwise? So
Sir,
basically,
it's in the
we are trying to
anti-clockwise direction, sir.
yeah, basically we're trying to align the leading edge of the tube into the broader area where you can negotiate it. If you look at the stride, normally when you are pushing it, it is going to the right side. So now if you are going to do anti-clockwise 90 degrees, what happens? The inverted V shape is there, no? The glottis shape is inverted
Yes.
V shape. The leading edge is going
Okay,
to
sir.
present the
The
90 degrees. Again, we are going to face difficulty. If we are going to do clockwise
narrowest
90
part.
degrees,
Okay, sir.
yeah. So the leading edge will come into the posterior aspect. It will facilitate
Okay,
the
sir.
easy passage of the tube. Okay, all right.
Okay, sir.
Then, so once you push the tube inside, then when you at what point will you take out your bronchoscope?
Sir, what's your question, sir?
Yeah, no, now once you push the railroad the tube inside, and when you will take
Yes,
out
sir.
the scope, you push
So
the tube
once we have,
inside.
yes, sir.
Yes.
So once it is inside, we will be actually taking out the bronchoscope slowly, sir.
So that's what.
So,
So what do you mean by inside?
sir, that can be seen at the level of the nostril, like how
No,
much
no.
distance.
See what happens sometimes when there is a hung up happens, and
Yes, sir.
sometimes you try to push the tube forcefully. At times what happens, the scope can come out of the trachea and then scope can go into the trachea, esophagus. Because we are going to push it, the scope can come
Push
out.
it.
So once you push the tube inside, the tube is gone. You have some resistance. You are maneuvering the tube, and the tube has gone inside. That doesn't mean that the tube is there in the trachea. You have to visualize the tip of the tracheal tube and then your tracheal ring or a carina. You have to see the carina little bit come out, you visualize some 3, 4 tracheal rings, and then see the tip of the
Yes, sir.
tube. Then only that is confirmed that your tracheal endotracheal tube is there in the trachea. Then you should take out the bronchoscope, right? That's why you confirm it. Okay.
Yes, sir.
Then what do you do next step?
So then we will be connecting it to the circuit and we'll be checking whether the capnographic curve is correct, sir, to check for the position of.
Why do you want to check with the capnography?
Sir, because I want to confirm the tracheal intubation, sir.
Then what you've done now? You have done the direct
Sir,
visualization.
yes, sir. Yes,
You
sir.
directly, directly. That is the reason you have to
Yes, sir.
see the carina. Yes, that confirms that the bronchoscope is inside. Then withdraw the scope, visualize 3 or 4 tracheal rings, and then see the tip of the tube, and then take it out. Once you can confirm that, that is the only confirmation that the tube is inside. Suppose you should not wait for the bronchoscopy to confirm. Wait for the capnography to confirm. Correct?
Capnography. Yes.
All right. Okay. Then
Once that is being done, we will induce the case. Then only we will be inflating the cuff, sir.
why?
So because even that stimulus will be actually causing the stimulus for the patient, sir. So to avoid that, we'll be first giving induction. Then only we will be inflating the cuff, sir.
Already you have anesthetist patient, no? And then we can very well inflate the cuff.
So mostly we wouldn't have uh, anesthetized the part lower to the vocal cord, sir.
So where the tracheal cuff is going to be? Just to you
Yes, sir.
anesthetize the entire airway, no? So once you confirm, you can inflate the cuff and then induce the patient. Okay.
Okay,
So
sir.
because your another priority is you need to prevent the aspiration. Okay. So
Yes,
inflate
sir.
the cuff and then you can anesthetize the airway. Okay. Then what next? How will you induce the patient?
Sir,
So
will
how will
be
you induce the patient?
Sir, we would like to give fentanyl 1 to 1.5 mics per kg for this patient. Second, we would like to give injection propofol. We have already secured the airway. We have inflated the cuff and ventilation is ready. Since an IV line is present and functioning, we would like to do some IV induction. But the dose of propofol we would like to reduce because initially for laryngoscopy and intubation is the high dose requiring. So to for propofol, um, um, we'll assess the um, vocal response of the patient. and we'll maintain oxygen flow of 6 liters per minute. Then relaxant, becronium 0.1 mg per kg for this patient, around 4 mg per. Yes.
Yes. So you have mentioned that you will be giving the fentanyl. No, there's no need to give fentanyl at this point of time. So you are here. Your priority is induce the patient. Okay. What is the purpose of giving fentanyl?
To avoid intubation response.
Already you have anesthetized the patient. You have anesthetized the patient, and then you put the tube in. So that is not going to reduce the intubation response, right? Because that's not going to happen. So we need not give fentanyl. You can give that. The fentanyl may be coming for analgesia, but that you need not give it in the beginning. You can give you can induce the patient using propofol or typhoid, whatever, and then you can give fentanyl later on after muscle relaxation and everything. Okay. Now this patient, you are trying to do the spraying. We'll just go back. We are trying to spray the cord. That time the patient is suddenly had a laryngospasm. How will you manage? You understand the scenario? You are in the nasal cavity. You are trying to put the scope and then go near the cords and then want to spray. At the time before you spray the cords, some movement happened and then patient went into laryngospasm. So what will you do?
Increase the oxygen supplementation, which we have already been giving through the nasal cannula. Also, we can increase the oxygen flow. Normally 4 liters, 2 to 4 liters we'll be giving through the fiber optic bronchoscope because we have already inside. This will be increased. Second is like we are forced to give muscle relaxant, especially a depolarizing muscle relaxant in this situation to relieve the spasm. So succinylcholine will be forced to give in this patient, even though we are not controlled there, because laryngospasm can be life-threatening in this condition.
So the first thing is you can take out the scope and you can use the mask to provide the oxygen. Not that we are just going to increase the oxygen by the nasal prong. You have to have a circuit ready for circulatory system or brain circuit, and then from there you try to give the oxygen and then hold the mask tight and then do it. We are going to provide some positive pressure that might break the laryngospasm. Okay, it's not very common in these patients, but if it all happens, that's why you do it. Okay, then we try to improve the oxygenation. You wait for some time that it may break. If not there, you can administer succinylcholine. Okay, so yes, then. So in this patient, what are other concerns? So why did you put a flexometallic tube for this patient?
So flexometallic tube is like kink resistant. As well as it is flexible enough to for a surgery of the oral cavity. So that is why we went for an nasotracheal, as well as it is kink resistant, so we can position the tube to the way we want during anesthesia.
Where do you, suppose we are we have placed the PVC tube, where do you expect the kink to be, or why you are bothered about the kinking?
Once we introduce, it will be outside the nares at the end, lateral part of the nares. That is what most common place for kinking of the tube, because the circuit as well as the anesthesia workstation might not be at our end, because the surgeon will be operating from the head end of the patient.
Okay, so now in this patient, let us assume you have placed a PVC tube. Okay, and you have one tube, but the flexometallic tube was not able to, you are not able to pass it. So you need to change to PVC tube. Now surgery is undergoing. So how do you monitor the patient to identify the tube kinking? What are the monitors you will do to identify whether the tube is getting kinked or not in case of a PVC tube?
For a PVC tube, one is the peak airway pressures um, to be monitored continuously, and EtCO2 trace also to be monitored continuously for any rise in peak airway pressures without a rise in the plateau pressure. That is how normally an obstruction. Especially can be identified as sudden fall, as well as the EtCO2 trace might take a sudden fall during the procedure, ongoing procedure, when the patient is like
No,
during complete
what did
kicking.
you say the EtCO2? What will happen
So,
to the
if there is complete obstruction, the EtCO2 trace might come to zero. There will be no EtCO2 trace, which is possible in the complete kinking of the tube.
No, but normally when you are monitoring, we don't expect the patient to have the complete obstruction, correct? So we will be trying to prevent it before that, correct?
Yes, sir.
So one thing, suppose patient is on volume control ventilation, you look at the peak airway pressure. Suppose
Yes.
patient is having a pressure control ventilation, then what do you do that time? Suppose patient is getting maintained through the pressure control ventilation, then how will you monitor the tube
The
kinking?
expected tidal volume we should be looking at, sir.
Yes, good. Okay. So that is another main concern in these patients. Okay. And he told that this patient is having a flexometallic tube. Is the flexometallic tube resistant to kink? Or still there is a possibility that it might also get kinked?
It can get kinked, sir, but not to the level of PVC tube. It will be because of an shared airway surgery what we are going to do here. So we have gone for a flexometallic, sir.
No, where it can get kinked?
So mostly at the level of nostril only it will get kinked, sir.
Yeah. So see, the flexometal, the reinforced wire is there. The tube
Yes,
cannot
sir.
get kinked. Okay, but only at the level of the tip and where the endothelial tube connector is connected
Yes, sir.
to the tube, only at these two areas there is a lack of reinforced wires are there. So that part, suppose you put the tube further inside into the one of the doing some process that can cause kinking, or if you are not very careful, maybe the endothelial tube connector they can get kinked. So that is again, if you are using the flexometallic tube that is not resistant to the kinking, so you need to keep on monitoring the patient. All right.
Sir.
Okay. Okay. This patient, what is the plan for extubation?
Oral at the
Okay. So
end of this.
yeah. So before we take the go for the extubation, we have some questions there in the chat box. So they're asking, is there any role of transthecal injection to anesthetize the trachea? Why did you go for the Stego? Why not the transthecal injection?
Our main concern for this patient was the toxic dose, because the weight of the patient is only 41 kgs. Second, transtracheal is only for the below the glottis level. So above part, again, we'll have to take care with nerve blocks. When we calculated for the other techniques, 5 to 7 ml for bilateral superior laryngeal nerve block, as well as all those things was exceeding the toxic dose. That's why we went for the SECO technique in this patients. Transtracheal, yes, does have an effect, but in this patient, our concern was toxic dose because of the low lean body weight of the patients.
The transtracheal is another alternative where you can anesthetize. How would they give transtracheal injection? That's shortly. Shortly, you have to unmute yourself.
Yes, sir.
Yeah.
Sir, how much
So
we will be giving in the transtracheal?
No, how will you perform transtracheal injection?
Sir, actually, for that, first we have to identify the cricothyroid membrane, sir. So in the cricut, when this can be done by laryngeal handshake method, we can do that, and we have to identify the cricothyroid membrane. Once the cricothyroid membrane has been identified, we have to insert. Mostly, we have to insert a venous cannula in that one. So this needle will be directed corded. So we are not going to injure over the vocal cord. So you should be directing it corded. And once we are getting the pop off, then we have to aspirate for the air. That is a short sign that we are inside the trachea. Once that is being done, then we have to keep our syringe, and then we have to again aspirate for the air. Then we have to give 1% of lignocaine.
No, you want to keep the needle inside, or you want to take out the needle?
No, sir. No, sir. I'll be taking out the needle. Then through the cannula only, I'll be inserting the syringe, and then I'll be again aspirating, and then give the local anesthetic into that, sir.
Yeah, so it's important to take the needle out. Otherwise, when the patient is
Yes, sir.
coughing, it causes the breakage of the needle, right? Okay.
Yes, sir.
And what about the another question is that the role of nebulization with a 4% xylocaine?
Sir, actually, with nebulization, actually we can cover both the nostril as well as the nasal, as well as the oral also can be covered with 4% of lignocaine 4 ml, sir. But it's kind of an alternative. Whatever the preference the anesthetist concerned anesthetist is having, it's up to the preference of the anesthetist who is being using that, sir. Whether what they are preferring, what they are comfortable in using, that is the thing. Otherwise, this will also be having a much of effect on the patient. Like anesthetizing part also will be better with the nebulization as well, sir. But some otherwise it has been told like this nebulization is not in some literature it is saying like it won't be
No.
well
See,
enough to anesthetize.
in the exam, you should not tell that it
Yes,
is
sir.
given the literature, those things. You need to tell the facts. Okay, you should not tell that
Yes, sir.
it is given the literature, that is the answer. Correct? Yeah.
Yes, sir.
Yeah, please go ahead. So you were telling correctly. Yeah. Can you please repeat it?
Yes, sir. Actually, with nebulization, we have to use 4 ml or 4% lignocaine. Sorry, 4% lignocaine. So this has to be given for at least 15 to 20 minutes. It will be requiring so we have to be waiting for that much time. We should be letting others also know like how much we are expecting from this one, sir. This will actually give a better anesthetizing to the nasal as well as the oropharyngeal areas.
Yeah. So this nebulization is a good technique. That's another alternative. The only there is a slight issue is there because the pressure receptor there at the base of the tongue at the vallicula that are slightly situated deeper. So when you want to anesthetize that area, you need to have more local anesthetic go there. With the nebulization, that may not happen all the time. So that's the reason if you do the stage 4, it will be easier to go to the area and then spray the valvular part. And then at the time of putting the tube, the gag reflex will not be there. So, but otherwise, nebulization is another good alternative. That is good there. Okay. So, is there any questions from the other participants? You can just put the chat box.
About this nebulization,
Yes,
I
Monty.
feel it's, the consistency of nebulizing working, it's not 100%.
Correct.
Nebulization is designed to reach the particle size. Nebulized particle size is designed to reach the alveolus, although it will also deposit in the other areas also. We can't be consistently relying on nebulization as an assistant. Other airway anesthesia methods plus this might be good, but only nebulization might not be enough.
Yeah, correct. So again, we need to be individualize the patient. That's the problem with the nebulization. As you told that it may not reach the vallicula in all the patients. Okay. So what about the extubation? What is the plan for extubation in this patient? So what are the concerns? What are the things you will have it in mind to decide about the extubation? So patient underwent
Sir,
what surgery?
Sir, the patient has underwent a surgery in the oral cavity. So we are expecting some laryngeal edema and vocal cord edema to happen in this patient, sir. So that would be our main concern. So if at all we are going to pull out your tube, there shouldn't be any closure of the airways. So for that case, we can deflate the cuff. Cuff leak test can be demonstrated in the patient, sir. If
So
at
but
all that
why do you expect vocal cord edema in this patient?
So, because of the surgery that has been done in the oral cavity, that can
Okay.
be laryngeal edema that can happen. There is high risk for this patient to develop laryngeal edema. Sir.
Now, why the patient will have the laryngeal edema? The surgery is going to be on tongue or there's a CHE.
Yes, sir.
So normally what they do is they'll push the tongue and then do the wide local excision. Okay, then you are expecting the edema there in the nearby structures, that is near the tongue.
Okay.
If at all they go to the posterior part of the tongue during the
Okay, sir.
while they're handling the thing, it can cause a tongue edema. Okay.
Yes,
Basically,
sir.
the airway edema, not
Yes,
necessarily
sir.
your laryngeal edema. In case if you
Okay,
are
sir.
trying
Yes.
to have injury during the airway manipulation, that time it can cause vocal cord edema. Otherwise, you are not expecting the edema there, right?
Okay, sir.
Okay.
So for that, we will be deflecting the cuff, and we should be seeing like how much is the cuff leak test. So if it is greater
Swati, the
than
problem
110
we expect here,
is
is upper airway
okay.
obstruction,
Okay,
not
sir.
lower
Okay,
airway.
sir.
The cuff leak test
Okay,
is
sir.
for obstruction at lower level.
Okay, yes, sir. Yes, sir. So
Alright.
in this case, we can use an airway exchange catheter, sir, before extubation.
No, again, so see, in this case, we are expecting there is a the upper airway edema. So you need to make sure that the upper airway edema is there or not. So then you need to decide. So one of the first thing is the decision to extubate. Are we going to electively ventilate this patient? Or are we going to extubate the patient? That is the first decision. If at all you are going to extubate, then we can plan for the extubation. All right.
Okay, sir.
Okay. So what is your concern? Like how do you decide?
Sir, I would think of electively mechanically ventilating the patient depending on the duration as well as the other characteristic of the patient. Second, upper airway edema is suspected in the suspected or expected in this patient because of the retractors and other manipulation, surgical manipulation, which was done in the oral cavity, plus a flap or thing. Flap which might be placed. Restriction of the neck movements also might be advised from the surgeon perspective. The second thing is it is already a difficult airway with limited mouth opening in this patient. We have done an awake, so I would like to delay extubation in this patient. Provide anti-edema measures in the form of methylprednisolone or dexamethasone for the long term for edema control, and extubate on a later date for this patient. This kind of patients.
So because here you are generally we are expecting a airway edema. Okay, definitely there is going to be a edema there in the posterior part of the time, which will not be able to access. So it's better to you wait. Don't extubate the patient on the table. You can wait for give anti-edema measures or dexamethasone. You can wait for next day. You can once again you have to assess the airway. Maybe with the tongue depressor you can see the any edema is there or edema has come down. Then you can decide. Okay, so how will it? For example, suppose this patient you are electively ventilated for overnight. The next day morning you are only going to extubate. So what is the plan for next day?
There are certain goals which we need to adhere while extubating this patient, sir. We have to decide whether we are going to do an awake extubation or a deep extubation. In the ICU setup, for a difficult airway, we always go with the fully awake extubation, where the patient is able to protect the airway. One
So
thing
what
is
do you
that.
mean by see, the deep extubation is always under anesthesia in the OT.
Yes, yes.
Okay, so that is not the concern at that the ICU. ICU is always awake extubation, not the deep one. It is under the OT, right?
Yes.
Okay. So here in these settings, mostly we'll be giving some sedatives for the patient during the overnight, just for the patient to tolerate the tube. So would you like to change anything that one?
We need to stop the sedation well prior to the planned extubation. In case we are giving fentanyl or fentanyl plus midazolam, at least 3 to 4 hours before the extubation, the patient is able to obey the commands, as well as drowsiness is not there. We'll have to give adequate time. And second is additional help. Always extubate the patient with difficult airway when additional help or is available on call or during the time. Preferably during the daytime, extubation to be preferably during the daytime. Second, reintubation, all the equipments for reintubation of the airway in case of any untoward incident. Or a need for reintubation is present, we'll have to arrange prior before trying to extubate this patient. As far as the patient's assessment related to the extubation is concerned, we need to be sure of the airway edema, whether it has subsided. So we'll first assess the patient with the oral cavity. If there is no any tongue edema, we can use a simple tongue depressor or even a laryngoscope blade for introduction, because mostly the mouth opening should have improved by the time we have done the surgery with such kind of patients.
The main thing is once we need to examine, we have to ask the surgeons also to see, because they are more used to assess the posterior part of the time. It's a team effort. Once you convince that there is no significant airway edema or there is no edema, then you can go ahead and do the extubation. Would you like to extubate the patient in the OT or would you like to extubate the patient in the ICU itself? How do you decide? Okay, so if you think that it will be after extubation, what are the complications you are expecting? You might expect a reintubation, right? That's what your most difficult concern. So in that case, you decide about your manpower, your skilled help is available, and you have the things to reintubate if at all necessary. If those things are there, you can very well extubate in the ICU itself. Okay. Can we put the airway exchange catheter in the next debate?
Yes, sir. We would recommend putting an airway exchange catheter for such kind of difficult airway scenarios. Introduce the airway exchange catheter.
But why do
extubate?
But what is the but why you want to use the airway exchange catheter?
Through the airway exchange catheter, oxygen supplementation can be ensured. as well as railroading the tube in case of difficult
So
scenario.
the idea is even though you do the assessment, you will not be able to go to the posterior part of the time. Okay, so that is the assumption that we wait for we give anti-edema measures, wait for 24 hours. If the edema there at the lateral part and the anterior part of the tongue has come down, that is assumed that the edema there in the posterior also will be has come down. That's the assumption. So we'll not be able to assess clearly, right? That is the reason you use the airway action catheter and then extubate and then wait for couple of hours to see that there is no edema or patient is not having showing any signs of upper airway obstruction. In that case, you can take it out. Or if you feel that still the edema is there, patient is showing signs of airway obstruction, that time we can go ahead and do the railroad the tube or the bougie or the airway catheter. And the meanwhile, you can use the oxygenation also, right? Okay. So there are couple of questions there. Dr. Mohan, can you please take those questions and then?
Sir, experience of tracheal trauma due to full force intubation, rupture of membranes. I think this kind of trauma happens, if at all it happens in emergency situations. When the airway view is not poor, say there is bleeding, when we do things in a hurry. In a planned intubation, planned auric fiber optic intubation, we keep reinforcing that. We never push against resistance. We follow that. This is unlikely to happen. Extubation over AC, we have discussed that AC can be used. Use of North Pole Vortex tube through fiber optic. So North Pole tube has two bends. It is very difficult to, even if you soften the tube with warm water, soften it and straighten it, it will be difficult to have a fiber optic bronchoscope through a North Pole tube. We have used that for periodic south-facing tubes. North Pole is in a certain specific position.
Yeah, that
It's
is
best use of
difficult to use it, but
flexometallic tube, which can be turned.
Yeah, the preformed tubes, it is difficult to put the fiber optic, but people have done it. The reports are there where they soften the tube and then somebody has to hold it and then do it. So, but usually it's not very easy to do it that way.
When we have a good alternative, a flexometallic tube gives us the same advantage.
Yes.
And shall I add to that, Dr. Lenin?
Yes, sir, please.
Because when we are already doing a nasal intubation, we are not sharing the airway with the surgeon also. So whether we use a flexometallic or we use a North Pole Vortex, it's one and the same thing. But rather the flexometallic is soft and easy to insert, little trauma, everything. So I think there is not much advantage of any North Pole. Rather, the hardness of it can cause more tissue injury in the nasopharynx also, other structures also. I think flexometallic is the best choice. You can always position it with the circuit wherever you want to put, whenever you rotate the head, because in this type of surgery, the motion of the head and just to expose the surgical area, you have to do it many times. So flexometallic is the ideal tube for these type of surgeries, I think.
Sir, yes. And there's another question about depth of insertion of the airway catheter. So the available catheters usually they have a markings at what is the length of the airway catheter. Usually it comes around 50 to 60 centimeters. They know the markings are there. So we have to make sure that the tip of the airway catheter is reaching the tip of the endotracheal tube. We have to have the calculation and then do it. But there are some bougies it comes without markings also. So in that case, what I do is you take the similar tube, you measure how much the length should be inside the endotracheal tube. Only put that much distance inside the endotracheal tube and then take it out. So by putting blindly, keep on introducing the active catheter, that only is going to cause trauma. You have to measure the length of the endotracheal tube and the length of the bougie and then put correctly, right?
Yeah, I think it's a very simple physics, very basics type of things. Before, I think planning, because it is already anticipated. When we plan, just do the simple physics of measuring each and everything. Life become very simpler rather than having later on any complication. They're very basic steps, I think. Very easily and nicely explained, sir.
Yes, sir. Fine. I think is there any other questions, sir, we can take or?
Tisha and Mac, any other question is there in the chat box which we still have to answer?
So one more question. Dr. Praveen Kumar is asking, North Pole can't be exchanged with AEC whole extubation as it is pre-shaped?
Yeah, that is I already told the difficulty with the North Portex is, or whether Portex or any other tube. The North Pole is always going to have difficulty. It's more importantly used where just the positioning of the head is required. Here there is something different. We are going over the, already bypass the cavities. And exchange catheter definitely is a difficult, is a rigid, more rigid than the flexometallic. So already I think that been answered. So flexometallic is the tube of choice in these type of surgeries because the motion and don't know the how much of the carcinoma has been there, how much type of how many type of movements have to be done. I think almost every 2 minutes, sometime to for the hemostasis, sometime for a better surgical exposure. It will keep on rotating. The position will keep on changing every time.
Yes, sir, you are correct.
Mac, any other question you have noted which must have been asked previously?
Question, sir. How do you handle bleeding during fiber optic bronchoscopy?
Oh,
I
yes.
think fiber optic bronchoscopy. I will just answer for Dr. Lenin. Must be tired for the 2 hours he has been doing. See, you already have a good fiber optic bronchoscopy. Your suction port is there. I think whenever you are prepared for the fiber optic bronchoscopy, you always use the measure before that. Whenever you this one sprinkle the nasal cavities and other areas, you do with some time of the this one go for the nasal decongestants that at least give you some space, then some protection, and the suction port is always active in the fiber optic. I think in these type of cases, it's always my advice is rather than the naive one, the experienced hand should be the first one to handle this case because once bleeding starts, it becomes very difficult even for the experienced learner also to negotiate these curves and all those areas. So when an experienced person is there, he knows the fingers will be the guide, how to proceed with the fiber optic, how to negotiate the whatever you call the opening spaces between the tumor and the glottis. So this is a very good navigation. Here comes the role of the experienced person like Dr. Lenin sir, because this type of cases, uh, they have to be handled very meticulously. They look, do you think that having a fiber optic is a very good armamentarium, very good weapon in your armamentarium, but it has to be used judiciously, even in these cases also. Because even sometimes bleeding may be a rampant, the suction port may also get blocked for the fiber optic, and you may be, our patient is already maybe using awake or under anesthesia. You have to do the process again and again. That will cause the difficulty of airway management more vigorous in the coming few minutes. So it's better always that these cases to be handled by the senior most experienced person, not just senior most experienced person who has been handling these cases. Because this is not, you can always guide. The TV is there, the screen is there. You can supervise, you can tell them this is the way to go forward. If any complication happens during this procedure, this is how you have to see the how to handle that one. I think this is the best way of learning from these type of cases.
So one more question is pending. Is it better to use suction or oxygen through the suction port? Which one is better?
I think we have covered that. Just to, want to add one more point to Dr. Bajwa there about the bleeding. So the bleeding, it can happen at the level of the nasal cavity, or it can happen at the level of the where the tumor is there in the tongue, cheek, or wherever it is there. So if at all, as that rightly pointed out, there should be experienced person doing it, and your main aim is to avoid the bleeding. That you should do everything to avoid the bleeding. If it all happens, if it is nasal bleeding, maybe you can just put the tube inside. That will give the some temporary effect for some time. But if the bleeding happens at the level of the tumor, that we cannot do anything. So we just go for alternative thing. That's the only solution. I think other questions we have covered, madam.
Decision of extubation is more difficult some. Yes, decision of extubation is difficult in these cases, especially if the surgery is very radical and airway is more difficult. So if the both the factors are combined, I think we have to be relying most upon the patients, our patients, and the clinical stability of the patient to extubate this patient in the ICU always, rather than the operation theater itself.
Yes, sir. So when you are in doubt, always wait for one more day.
Yeah.
Because that is difficult to assess edema is resolved or not. If you are in doubt, better always wait for one more day and then let the edema settle down and then extubate.
I think the next question, to retain the flexometallic tube for overnight. There is no harm in if you use it overnight ventilation also. And I think changing the tube at this stage is going to be more traumatic. Already that the area has been surgically incised and has been operated upon. And why to take unnecessary this one the risk of touching those areas and dislodging the surgical sutures or surgical stability of that particular area. If the you want to overnight ventilate even with the flexometallic tube, there is no harm in doing that. Better to extubate only once rather than changing again over the catheter with the another tube. It's better to go with the flexometallic overnight ventilation.
Yes. So only precaution we need to take care here is the flexometallic tube. You will be fixing it there at the nostrils, but still patient can have an accidental extubation. If the patient coughs out, the tube can come out of the trachea and then you can come into the oral cavity. Still the tube is fixed to the nostril. That is one possibility because it is flexible. So we need to be make sure that you give a sedation for this patient to tolerate the tube. That is the very important thing. But again, the another technique is we have to be careful, as I was telling, with changing the tube in the middle of the night or late night with the case going late. So that is going to be a challenging thing. So we need to take care of that one. Tracheostomy to be done before surgery when profuse bleeding. Yeah, that is another option is available because when the bleeding is happens, fiber optic is not going to be of use. So obviously we need to go for your plan B. Yes, you are correct.
Yeah, it's a life saving also sometime because the tumor, if the tumor is vascular, that means you are going to be in a trouble even if you attempt second or third time. So better go for tracheostomy, much safer, and
Yes,
you can always do that. I think we have already ended up the questions, and it's time for us to have some felicitations of our people who have done such a beautiful job today. Wonderful. It's a long time. It was a difficult thing. And Mac, is my screen visible?
Yes,
Oh,
sir.
yes, sir.
Yeah. So I'm really very thankful. Myself, Dr. Madhuri, Dr. Ritima, Dr. Nishant, and Dr. Mehak and Dr. Tisha. We are really thankful that we are a very wonderful team who have covered this topic so meticulously because this is not a simple topic. People may be thinking anticipated difficult airways is a simple topic. It's never. It can never be. So I'm really thankful to Dr. Lenin because Dr. Lenin, in spite of so many schedules and busy schedules, it was ultimately the class done, and that's a good manner. Thank you, Lenin sir, for being the leader of this class.
Thank you. Thank you very much, sir.
And Dr. Mohan Vikes, it's nice to meet you in the class, and your inputs, your deliberation. I think you might also have prepared the PG student. It was very meticulous, and thank you for that. It's a small gesture from our side to felicitate you on for this class. And Rickson, I can see the confidence, and you agreed to that thing. No blunders, and the way you were answering, I think you have already prepared yourself for the finals. So thank you very much, Rickson, for preparing this class so meticulously and giving the PG along with Swati also. She is also good in
Thank you,
answering
sir.
almost everything. So both of you, I think, qualified for the pre-finals, and I think I will put a sifarish on Dr. Lenin to make you pass in the first attempt when you appear for the final. Okay.
Thank you, sir.
And Mehak as well as Tisha. I'm really thankful to both of you because you have been anchoring this class and always a debut for people like you to be into these type of classes, and it's just an national exposure, and you prepare for the next step where you will be presenting small things. And Dr. Madhuri is always there, Dr. Ridhima is there, Dr. Nishant is there with me. Nishant is busy in the conferences nowadays. So after the conference, he will be coming back to the classes again. So this is how our team prepares, and I think very good. And it will be available on ISA NHQ YouTube, where it can be seen every time. Anybody can see this class, go for the questions and different answers whenever they're preparing for the finals. It will be a permanent property of ISA, freely available to all its ISA members. That's what we can say at the moment. Somebody has asked a question again before going. Botroclode also might help in bleeding episodes. I think more on the surgical side, we use this Botropase and all those type of drugs where they do have some thing. Then I think I don't know the role of tranexamic acid in these type of cases, how much they are really helpful, because the vascularity and the bleeding pattern is different than whatever the surgical wounds pattern is there. So here is not about the coagulation, it's about the more of a friability of the vessels that is more important in controlling the bleeding. So where we have to be very meticulous in handling the airway. That is my opinion. Dr. Lenin may have to add something else also. Or Dr. Madhuri wants to add something else.
I totally agree. I think this when the bleeding is there, better to should not be keep on persisting with our existing plan. We need to move ahead and then plan for the plan B. That I agree. But I am not having any experience with this water plot, so I will not be able to comment about that.
Yeah.
I think somebody raised hand.
Yeah, Dr. Mohan Patak has raised hand. Let me also make one thing, because I have to change some settings also because people. Dr. Mohan sir, you can ask the questions by unmuting yourself.
Sir, this was
We would like to
very
see on
unusual case. Unusual case after intubation for the thyroid surgery. That was not a difficult intubation. But after some time, patient started sinking. She had a cardiac arrest, was not revived in this case. Later on, we found that she had a bilateral pneumothorax. After giving the position, a neck extended and patient started fainting, and then they noticed patient is arrested. And on X-ray portable, we found bilateral pneumothorax. Can it be happen because of the tracheal injury? The membrane between two tracheal rings can be perforated with the forceful intubation. In such cases, maybe. So, any experience about regarding that, sir?
Sir, did you do any this one CT scan or
there was no
MRI of the patient post-operative?
Post-operative X-ray was done.
No, not
Plain
X-ray.
X-ray. And patient was not survived. Patient
See, it's a
did not survive.
bilateral. It's a bilateral because even if you tear a
Pneumo.
membrane, it will go in the one direction only. The facial structures are.
Yeah.
But in these type of cases, what I'm telling you here, what I have experienced is, in certain cases, there are, basically the emphysematous chest is there, which may not be picked up during the clinical evaluation sometimes. Even
There was
sometimes what happens
bully.
when we ventilate these patients, sometimes what happens from the workstation or from the machine, the volume trauma occurs because the gush of air is to that much volume goes that it suddenly pierces all the facial planes and it can cause bilateral pneumothorax. So that I've seen where the air is not controlled, the pressure of the ventilator or the whatever the workstation is not controlled. That can be one of the causative factors. That's why we always ask the services of these workstation and ventilators to be done regularly, because sometimes.
Sir, this case was done at the small nursing home with the hand ventilation and very small voice apparatus. Hand ventilation only.
No,
I'm
just
expected.
not experience. I'm just telling you one of the causes that I've seen.
Maybe the lungs abnormal, diseased lung.
It can be multifactorial. It can occur anytime.
Yeah.
So that's why we report these type of cases so that they can add to the literary evidence and literary support for us. Message goes that whenever we handle these cases, at least we should be taking these precautions so as not to repeat these type of things in the future for the patient safety.
I have got only X-ray of that patient, which bilateral pneumothorax.
X-ray is not conclusive sometimes. X-ray is just supplementary diagnostic investigation.
She had a crepitus. She had a crepitus. Or
No, that is pneumothorax. Sir. Post pneumothorax X-ray is not going to help you much. It is just going to give you a
yeah,
picture of pneumothorax. But what was the causative
yeah,
factor? That is not going to be taken or given by a diagnostic accuracy by the X-ray.
yeah.
Dr. Madhuri is
But
silent.
actually,
Okay.
actually, Dr. Mohan sir highlighted the point that the bougie-guided intubation can lead to tracheal injury. That's the point. But it may not have happened in your case, but that's a valid point. Who are going to use the bougie, they need to use it carefully, introduce it gently, and then only the certain length is intended, not keep on introducing too much.
And bilateral is little bit uncommon with the
Bilateral is uncommon. Bilateral is uncommon, unlikely in this case, but we have to be careful with the airway devices. Yes, sir.
I think a good discussion, a good case discussion today. I think many people must have got wiser today with this type of discussion. In such a case, I think these classes, beauty of these classes is people may get tired with this class, but it's again available on IS NHQ YouTube. You can watch it tomorrow again. I think, Mac, you must be feeling the onco cases very with the coming with the, so much of the onco cancers, no, the oral cancers.
Yes,
But
sir.
you will be facing these type of cases tomorrow. You can say with the superiority, I've been anchoring to these classes where everything was explained so meticulously by the CHIPMA team.
Definitely, sir.
Yeah, that is here. Actually, these type of classes, they are beyond the guidelines or beyond the recommendation. You get almost every practitioner, the academician, PG students, everybody come forward to give their inputs and ask the questions, and everything is answered. So you get a wholesome of academic wisdom in these type of classes. Uh, Dr. Madhuri, you want to say something, or shall we close this class now?
So I think we can close the class because much has been already said.
Yeah, almost today. I think I'm really thankful to the team, my class coordinators, as well as the team of JIPMER. They've done a wonderful job today. And all to the audience who are still with, there's still many people from the audience are there. They are listening to this class.
And
Thank
only
you.
for the old-fashioned, for the old the people, the examiners, maybe blind nasal intubation, he did not cover.
No, because in these type of cases,
Yeah.
I think they should be referred to the tertiary care centers.
Definitely.
Because now the time has come of the legal,
Yeah.
implications and the advanced scientific material, airway guidelines. So in the court of law, one may not be able to protect himself or herself when you are doing such cases in a in what you called in the just a secondary care center or a primary care center. So these cases have to be dealt in the tertiary care centers where the experience is there, because the patient safety is paramount and your safety is also paramount, because the times have changed, the medical sciences has changed, the atmosphere in the country has changed, so you have to be very much protective of the patient as well of yourself also. So better to refuse these cases when they come in private practice. So always refer these cases to the higher center where team is there, where you can protect legally, clinically, behaviorally, psychologically, psychosocially, everywhere. So these type of cases should be handled. I will refer these cases to Mehak Tata Memorial. So they will be handling these cases, or to JIPMER. That's the best way to go. So I think we should end this class, and hopefully we will meet next time very soon in a similar for the JIPMER team. Till then, good night from the national headquarters, meeting from all the governing council members.
Thank you,
And
sir.
Yes, sir. On behalf of the JIPMA team, I sincerely thank the entire team, sir. Bajwa sir, a big thanks to you, sir. Thank you very much, sir.
Yeah.
So,
Okay.
Good day.
one more question is pending, sir.
Come on, we will answer that. Don't worry. Yeah.
Dose of
Yes.
adrenaline nebulization for suspected airway bleeding. Any insights?
Yeah, I was thinking that question might come, because when I was saying about the sprinkling some drugs about that, so it was coming to my mind. Somebody will definitely ask this adrenaline questions. So see, if the patient is not a cardiac patient, if the patient is not having cardiac morbidity, definitely, when the nasals, when an ENT surgeon, they use 1 in 2 lakh or 1 in 2.5 or 1 in 3 lakh of ADR. That I think that can be easily, or you can have a little bit, more concentrated adrenaline in the nebulization form. That is another way of going about it. But there is a no hard and fast studies and RCTs done on these things to establish the safety of a concentrated adrenaline nebulization in these cases. But adrenaline definitely have a role. But again, I told it's not about the nasal a vasoconstriction of the vessels. It's about the friability of the vessel that is very decisive in these type of cases. Because of the pressure necrosis, because overgrowth of the tissues of the tumor, the vessels become, very friable, very, very thin. Endothelium and exothelium both have reduced to a large extent, rather than even the sympathetic and parasympathetic, innervations of those vessel is also compromised. So you may not be able to land up in a real vasoconstriction state even with the use of adrenaline in these type of cases. So it's a better because it's more of a physical trauma, and you may not be having the autonomic, stability to control the bleeding with the use of adrenaline in these cases. You can, but I don't think so. It has an established role in these type of cases. Rest, I think even Dr. Lenin can also throw some light. This is my experience actually.
Actually, usually we give adrenaline nebulization for the airway edema. I don't have any experience to give adrenaline for the airway bleeding. I'm sorry for that. But we give 0.5 milligram adrenaline 5 ml saline for that is for the airway edema. Suppose we are suspecting airway edema, that time we'll give it. But I'm not sure about the airway bleeding. I have not used it. That's be a new learning for me.
Yeah, we keep on doing,
Adrenal
sir.
nebulization
Sometimes
can be
just
used for preventing, sir.
yeah,
By
we
decongesting, prevention might be possible, but when it is bleeding,
yeah.
nebulization is unlikely to be controllable.
Yeah, that's what I was saying, because at that time it is more dangerous. When the bleeding is there, the vessels are exposed, the absorption will be there, whether it's arterial or a venous or capillaries. The absorption mechanism become more, aggressive. The ADR is directly absorbed into the vascular structure in the tree, and the cardiac problems can be devastating if it's directly absorbed. We are using a concentrated adrenaline in those cases. So mechanism is different, but here is entirely a different case. Submental shared airway, can submental intubation be kept as an option? I think if you are uh, handling this case, this because the tumor, the extent is we don't may not be knowing properly unless until we have all the radiological investigation with us side. To what extent the airway is compromised, whether the submental intubation will be of any benefit in negotiating that particular area where that which tumor is occupying. That is another way of concern. So if the radiological investigation clearly says that some part of the track from that submental to the glottis is clear, okay, you can use, but only if you see that the nasal intubation, may not be having any path. But that is difficult to establish. Only under anesthesia you may be able to establish, because when you anesthetize such patients, the software, the soft tissues as well as the tumor, the muscles relaxes to a large extent. The airway which was clear before, maybe we are planning for submental, that may become more challenging once the patient is under anesthesia. Because doing a submental under without anesthesia is not feasible in these type of cases. You have to do under anesthesia. So once the relaxed muscles are relaxed after giving the relaxant, you may not be knowing how much of the tissue will be occupying the glottis area, how much it will be obstructing, whether submental will be more traumatic in these cases or helpful. Don't think so. It is easy to establish in these type of cases. Your opinion, Lenin sir?
Yes, sir. Actually, the submental intubation is optional when you do the oral intubation. After the oral intubation, there is a shared airway where the surgeon is operating the oral cavity. That time we can take the tube out of the oral cavity through the submental route. So here, so the other prerequisite is we need to have the oral intubation. So as you said, rightly pointed out, we need to have the understanding about the extension of the tumor, how big is the tumor. Then we can intubate through orally. That is one thing. Again, we are going to take the tube to one side. Maybe the right side of the tumor is there, we can take the left side. If that possibility is there, yes, we can do it. But in this case, where there is a restricted mouth opening, that is not an option to us. If the mouth opening is there, where we can place the oral tube, then yes, that is a possibility. But the only thing is we need to use a flexometallic tube, then only we'll be able to take it out easily.
Yeah, definitely.
That's the options are available is there.
Yeah. So I think it was such a nice team, cooperative team today, answering till 9 o'clock. And good, I think even our class coordinators, screen coordinators, they are awake today. So it's a wonderful class. I think we should end now. It's 9 o'clock. Thank you, sir. And thank you, Team Jipmer. Thank you, my class coordinators. Now we are ending the class formally. So we end by saying, long live ISA.
Long
Long
device.
live ISA.